In this video, I'm going to explain the colorectal cancer in details, explaining the risk factors, presentations, as well as the molecular mechanisms of the development of the colorectal cancer. But in order to be able to do that, I will first have to explain the mechanism of mismatch repair. So what I'll do for this video is that first I will go through different mechanisms of DNA repair, explain the disorders that are associated with defects in these DNA repairs, and then after that discuss the colorectal cancer. So the first mechanism of DNA repair is called base excision repair. So if there is a damage to a base, which is shown as a red triangle here, what happens is that the glycosylase enzyme will remove the base. So glycosylase removes the base. And then after that, the apurinic, apyrimidinic endonuclease will remove the backbone. So now everything is removed and a gap has been placed in. So at this stage, DNA polymerase and DNA ligase will go in and fill the gap. So the gap is filled and now we have the correct DNA right here. The next condition is nucleotide excision repair, which is commonly used for the repair of the UV light-induced formation of the pyrimidine dimers, including, like, for instance, thymidine dimers. And to be able to remove these pyrimidine dimers, there is a complex called UV repair endonucleases, which is composed of multiple different enzymes. And so these enzymes will form a complex, and unlike the base excision repair, where the damaged base and possibly the surrounding bases are removed, here with the nucleotide excision repair, a large segment of the DNA will be removed. So a large segment is now removed, and after that, similar to the previous mechanism, DNA polymerase and DNA ligase, so DNA polymerase and DNA ligase will fill the gap. The next condition is the mismatch repair. So what happens is that we have a template DNA and then we have a new DNA. So during DNA replication, there is a primer, and from there on, the DNA polymerase 3 will start to make DNA in a 5' to 3' direction. Now, while making new DNA and putting new nucleotides in, if there is an error in one of these nucleotides, then what happens is that this DNA polymerase 3 has the 3' to 5' exonuclease activity. So it will remove the base and then start putting a new one. So it's as if you are making a floor and you put a wrong tile in. So you remove the tile and put a new one in. So that's what the DNA polymerase does. Now, despite of all that, there is still a chance that the DNA polymerase 3 misses to correct for the mismatch of the bases. And so once the new DNA is made, there is still a chance, a few minutes after it has been made, for the DNA to be corrected via the mechanism of the mismatch repair. And how this mechanism works is that the template DNA is methylated. So the G, A, T, C DNA sequences are being methylated. And it takes a few minutes for the new DNA to be methylated. So this way, now the MUT-S enzyme is capable of recognizing the template from the new DNA strand. So what it does is that it will bind to the GATC DNA sequences and remove the base at the site that lacks the methylation. And from there on, via the exonuclease activity, it will remove all the bases until it reaches DNA mismatch. So here, all the bases from the methylation site all the way to the DNA mismatch is removed. And after that, the DNA polymerase and DNA ligase will again fill the gap. Now here you might have noticed that sometimes I'm using the term endonuclease and sometimes I'm using the term exonuclease. So the difference is that with the endonuclease, it can go in and open up a closed DNA. So here we have a closed DNA, it can go in and break it open. But exonuclease requires an open DNA. So here, since the MUT-S has already opened a site of this DNA, now the exonuclease can go and remove the rest. Or exonuclease can also work at the end of the DNA and start removing the bases from there. Versus endonuclease, it can start right in the middle and remove bases from there. And then the next form of the DNA repair is called non-homologous end joining. So if there is a double-stranded break in the DNA, via this mechanism, there would be some trimming of the bases, and then after that, the the two double-stranded DNA will be joined back together. So unlike the previous DNA repair mechanisms where a template was used and so you could still preserve the DNA and bring it back to normal, here with this mechanism you will lose part of the DNA coding, but at least you're able to bring back the two pieces together. Now, patients that lack this mechanism, like for instance the disorder of ataxia telangiectasia, these patients are due to the defect in the ataxia telangiectasia mutated gene. They lack the DNA repair mechanism required for bringing back the double-stranded DNA breaks together, and thus these patients present with the telangiectasias, ataxia, as well as IgA deficiency. So the memory aid that you can use is that ataxia telangiectasia mutated. So that's the name of the gene that is mutated in patients that have ataxia telangiectasia. And then the presentations include ataxia, telangiectasia, as well as lack of the immunoglobulin. So since there's IgA deficiency, you can think of immunoglobulin for the IgA deficiency. So these are the three presentations of the ataxia telangiectasia. And then with the nucleotide excision repair, if there is a lack of this mechanism, what happens is that now the UV light can make the pyrimidine dimers and it cannot be corrected anymore. So these patients will develop xeroderma pigmentosum. And the presentations of this disorder include sun sensitivity, skin degenerations, which you can see in this image, how the patient have skin as well as eye degenerations that are going on, which will eventually lead to the cutaneous malignancy. And then lack of the mismatch repair, which is an autosomal dominant disorder, can lead to the hereditary non-polyposis colorectal carcinoma, or Lynch syndrome, 80% of which can progress into the colorectal carcinoma. And this type of cancer always involves the proximal colon. So breast and prostate cancers are the most commonly diagnosed cancers. And then lung is the second most common diagnosed cancer, and finally colon is the third most common cancers. Now in terms of the mortality, despite lung is the second most common cancer, it's the number one cause of cancer mortality. So lung is number one cause, and then breast and prostate are number two, and after that colon is again number three of the cause of the cancer death. So the way you can memorize it is that C is the third alphabetic letter. So therefore, colon is associated with the third most common cancer as well as third most common cause of cancer death. And then you should know that the liver is the most common site of the spread of the colorectal cancer, and that virtually all colorectal tumors are arising from adenomas. Now here I have listed some of the colonic adenomas that have high risk of malignancy, and these include the tubular, which includes the pedunculated polyp. So this type of polyp has a stalk, and so there is a 4% chance of the malignancy. So here is an example of a pedunculated tubular adenoma. So as I mentioned earlier, it has a stalk, and there is about 4% chance of the progression into the colorectal cancer. And then the much more dangerous one, which is a sessile or flat polyp that has as much as a 30% chance of the malignant transformation. So here is an example of a flat polyp, which you can see that there is no more stalk right there. And then there is another type which is in between the two forms, and it's called tubulovillous, which is a combined form of a tubular and villous elements. So you should also note that this one has an intermediate risk of the malignancy, something in between the two. And the higher the proportion of the villous, then there is a higher risk of malignancy with this form of the adenoma. And then one last point I would like to mention in this slide is that not necessarily all polyps are cancerous. So there are, for instance, non-neoplastic polyps, like for instance hyperplastic polyps, which are benign. So keep that in mind. The adenomatous polyps are having high risk of cancer, particularly with the villus type, while the hyperplastic polyps are benign. Alright, next I would like to go over the risk factors to the development of the colorectal carcinoma. So I already explained that the adenomatous polyps are risk factors to the development of colorectal carcinoma. Now, age, particularly after the age of 50, is another risk factor to the development of the colorectal cancer, and thus it's recommended to perform colonoscopy every 10 years after the age of 50. Now, the reason every 10 years is picked for that is that usually it takes about 10 years on average for the adenoma to progress into carcinoma. So it's good enough to check for colorectal cancer every 10 years with the colonoscopy. Other risk factors include smoking as well as high fat diet with low fibers. And so these two factors, age, diet, as well as smoking, both of these account for about 70% of the colorectal cancers. Inflammatory bowel disease, particularly ulcerative colitis, is associated with increased risk of colorectal carcinoma, and to a lesser extent, Crohn's disease is causing colorectal carcinoma. Peutz-Jeghers is another risk factor, and this is an autosomal dominant disorder. Although the risk of development of the colorectal cancer is low, it's still some risk in these patients. Now, presentations of the Peutz-Jeghers includes presence of the hematomas along the GI tract, as well as melanin pigmentation of the lips, as well as the buccal mucosa. So here you can see that there are melanin pigmentations that are associated with the Peutz-Jeghers syndrome. Now, you should also know that in addition to the colorectal cancer, there is also this disorder is also associated with other forms of cancer, like for instance gastric cancer, breast, as well as pancreas. With familial juvenile polyposis, which is also an autosomal dominant disorder, there are more than 10 colonic polyps, which can be as many as hundreds, that appear during the childhood. And this condition is also associated with increased risk of colorectal carcinoma. HNPCC, or hereditary non-polyposis colorectal carcinoma, the other name for which is Lynch syndrome. I already discussed that with you. That is due to the defect in the DNA mismatch repair. It's an autosomal dominant disorder, and there is 80% chance of progression into the colorectal carcinoma. And then the final form is the familial adenomatous polyposis, or FAP, where there is 100% chance of the progression to the colorectal carcinoma. So all patients with this form of disorder will develop colorectal carcinoma. And this disorder is associated with autosomal dominant mutations in the APC gene. So APC stands for adenomatous polyposis coli, and this is located on chromosome 5. And so one memory aid that I have for you is that the word polyp has 5 characters: 1, 2, 3, 4, 5. So therefore, FAP is due to autosomal dominant mutation in the APC gene on chromosome 5. Now, there are variant forms of the FAP, and these are called Gardner syndrome, where in addition to FAP, there are osseous as well as soft tissue tumors, and it's also associated with the congenital hypertrophic retinal pigment epithelium. And then Turcotte syndrome is the final one, which is also associated with FAP in addition to brain tumors. And then the molecular genetics of the colorectal cancer has 2 mechanisms. So with the microsatellite instability pathway, there is a defect in the DNA mismatch repair, as a consequence of which mutations will accumulate. And so, as I discussed earlier, it can lead to the HNPCC or Lynch syndrome. And then about 10 to 15% of the cases of the sporadic colorectal cancer are also due to the same pathway. And then the next pathway is the chromosomal instability pathway, where due to mutations in the APC gene, there would be increased cellular proliferation. And so since now that there is cellular proliferation, therefore there would be more DNA replication, and thus there would be more chance of DNA mutations. So after that, colon is now at risk. Mutations that can follow include the KRAS mutation, after which there would be unregulated signal transduction that can lead to the development of the adenoma, and then after that, loss of the p53 can lead to the development of the carcinoma. So here I have provided you with a memory aid that is called AK53. So that's the order of the genes that are being mutated in the chromosomal instability pathway. AK53. So AK53. And then as for the clinical presentations, colorectal cancers present with the abdominal pain, weight loss, as well as blood in the stool. Now, in terms of the common locations of the colorectal cancer, the sigmoid and the rectum, these areas account for more than 50% of the cases of the colorectal cancer. After that, the second most common site is the ascending colon, and then after that, the third most common site is the descending colon. And so the presentations of the colorectal cancer can vary depending on the location of the tumors. So with the ascending tumors, its obstruction is unusual, and that is due to the large luminar diameter. So obstruction is unlikely to develop with the tumors in the ascending colon. So therefore, there would be no change in the bowel habit. However, these patients can develop melena as well as iron deficiency anemia. And so if you see an iron deficiency anemia in an elderly patient, the first thing you should suspect is a colorectal cancer, and you have to suspect that until proven otherwise. With the descending colon tumors, due to the smaller luminal diameter, now there is a risk of obstruction. And so due to the obstruction of a part of the bowel by the tumor, now that the stool is passing through, it will have a small diameter. So therefore, pencil stools is another characteristic of the descending colon tumors. And then one other common feature is also hematochezia, where patients can pass fresh blood in the stool. And then the last point I'm going to discuss for this video is the rectal tumors, which are most commonly associated with the hematochezia, where there would be passage of a fresh blood in the stool, and then these patients also have a feeling of the tenesmus. So tenesmus means that the patient has a constant feeling of needing to pass stools. So even after they pass stools, since there is a mass in their rectal area, they still feel that they need to pass stools, and that is referred to as tenesmus. And that concludes our discussion of the colorectal carcinomas.